Hi, I'm Dr. David Dobson. Welcome to Conversations. Today, my guest is Dr. Amanda Wurz, an assistant professor in kinesiology, and Dr. Lauren Ha, a postdoctoral research fellow, both from the University of the Fraser Valley. We are discussing their work on the power of movement and technology in pediatric cancer care. Amanda and Lauren, it's a pleasure to have you both here.
Thank you for having us.
Thank you. Great to be here.
You both are dedicated to ensuring that the cancer diagnosis doesn't stand in the way of healthy, active future. Amanda, I'll start with you. Given the weight of this work, was there a specific patient interaction or movement that originally drew your interest to the intersection of exercise science and pediatric oncology?
That's a great question. And there wasn't one single patient interaction. I think I've just always loved movement and I've always been fascinated by how people think, feel, and behave. And I just got really, really lucky that early in my training, I discovered exercise psychology, which is a field that's concerned with psychological factors that influence physical activity and exercise participation, and then how movement can also in turn shape things like mental health, motivation, and confidence. And kind of at the same time I discovered this field of exercise psychology, I was also exposed to cancer or oncology research showing that movement could meaningfully improve physical and psychological health outcomes during and after cancer treatment. And like many of us, I have known a lot of people in my life affected by cancer, young people and older people, and that really stayed with me. And I think it just became really clear really early on when I looked at the intersection of these fields that exercise, physical activity could really be this like pathway or this tool to helping people feel stronger, more capable, and connected during a really, really challenging time.
Lauren, knowing how much energy you have put into this area, what was the draw for you to move from general exercise science to this specialized world?
I always had an interest in cancer, but similar to Amanda, there was no one moment. I did my training in Australia, and in your last year, you do a range of different placements. And one of my practical placements was at a cancer center. And I just really enjoyed working with that population. And what drew me to pediatrics is when I looked further into the whole cancer population, I realized that there was nothing available in terms of exercise support for young children and adolescents. So that's what guided me and took me to my PhD. And a few years later, here I am, still in the field.
Wonderful. Both of you advocate that movement is not just a nice to have, but an essential part of recovery. How do you describe this shared thread when you first meet a family who might be hesitant about exercise?
Um, There, it's so tricky because every family is so different, and every family will experience different barriers, and reasons why they might not want to participate in exercise. It could be that they live really far away, or that they're not active before they were diagnosed with cancer. They don't know what to do. It might be too expensive. So there could be a whole different range of reasons, but one reason that I like to say is that treat it as if it's your treatment, it's your medicine. It has shown to really benefit young people and adults in many different ways. And I think being physically active is something that kids do anyway, whether or not you have been diagnosed with a chronic health condition or not. Playing and being active and running around with your friends is such an essential part of being a young person. And so, in a way, it's also just to take that back as well, and to feel those moments of joy in between treatments and hospital visits.
Oh, that was pretty perfectly said, Lauren. Yeah, I think I would share those same things. We often talk about the different benefits that physical activity can offer, both during treatment, after, and then after treatment as well. And I think for us, we really like to try to highlight the ways in which physical activity is one thing that maybe that family or child can do during a time when they're in a system and context that a lot of things are out of their control. So we try to share that. We always, depending on the age of the child, too, try to approach it in a fun and playful way. So indicating that it can be games, it can look so different. And I think that can also help with maybe some of the apprehension. And then, of course, these young children and people during treatment are also facing pretty horrible symptoms and side effects. And we have some emerging evidence in pediatric cancer and pretty strong evidence in adult oncology that physical activity is one way to actually lessen the severity of some of those effects. And so I think just some of it's just education around what physical activity can offer. Some of it's just supporting them to maybe continue movement that they're already doing, and then offering them the opportunity to maybe take charge and do something for themselves, or help their child do something for themselves. Yeah, during a time where they don't have a lot of control or a lot of say.
Nice. Lauren, you have written about the survivorship paradox. The idea is that while we are saving lives at these incredible rates, survivors face a 15-fold higher risk of heart-related issues later in life. How does early exercise intervention physically rewrite that trajectory?
Yeah, it's a tricky one. So the thing with being diagnosed with cancer as a young person and being exposed to such toxic treatments at a young age really increases your risk of cardiometabolic risks. And that at a young age can really be quite profound. And so exercise is one solution, one modifiable risk factor that we know of that can help reduce that risk, including reducing the risk of obesity, cardiovascular disease, hypertension, things like that. And so that's something that the patient themselves can control and that we can help improve and get them to start doing that in more regularly and more as a treatment.
One thing I want to add about survivorship in pediatric cancer specifically is that survivorship has changed dramatically in positive ways in like the last 30 years. So we are now seeing many different types of cancer. So children diagnosed with different types of cancers having relatively high survival rates and then living for decades after their treatment completion. And so they're going on to live these long lives. And I think with us in this exercise space, we're now really trying to shift the focus from cure to care. But I think we need to start thinking beyond treatment completion and asking, like, how do we help this growing cohort thrive for the decades of life that they have ahead of them? And yeah, exercise and movement can just be a relatively simple, and it's not to say it's easy. Physical activity behavior change is a whole field, and there's a lot of things that stand in people's way, and then you layer on a chronic condition. But it's something that somebody can do to augment their ability to thrive.
Survivorship, that cohort is such a unique population because survival rates have increased drastically over the years and they're continuing to increase further. And so that means that treatment protocols are continually changing. And so actually the survivorship profile of each person right now is very different to what that survivorship profile looked like 20 years ago. And it will also continue to look different to survivors 20 years later on. And so it's the thing of, cancer cure is not enough. They're going to continue to experience a whole lot of health consequences, and it's a changing population, and exercise is something that we can control and hopefully support them in.
Good point. Lauren, looking back at your work with the iBounce program in Australia, which is an online platform designed to teach survivors about strength, flexibility, and goal setting. What did that experience teach you about the challenges of reaching families who are geographically dispersed?
Yeah, so IBM was a really fun program. I had such a cool opportunity to work with a industry partner who developed the program, and it was initially developed for kids at school, so without any chronic health condition.
Okay.
And I had the opportunity to adapt it so that kids who had finished cancer treatment could use it at home. And that learning experience it was steep, especially going into the technology space and learning more about apps and how they all work. And I think testing it was interesting. Like for one learning and one great feedback that we got was the app didn't have a back button. So every time you clicked on things, it would take you to the next step. But if kids clicked too quickly, they missed what it said, they couldn't go back. And so learning the back end of apps and how to put in a back button into all these different modules was going to be like a year's work. And so I think that kind of scarred me from apps. And just learning just the technology side. But then on top of that, we also developed some exercise videos, and these were not super flashy. We won't win any Oscars with it, but from just basic video filmed by our exercise physiology students. Our participants actually really liked them, and it taught me that the videos you make don't have to be super high end. It just the content is far more important. So that there's some learnings from that trial.
Amanda, taking that clinical science and scaling across a country as vast as Canada, that lead us right into the IMPACT trial, which stands for the implementation of physical activity for children and adolescents on treatment. The IMPACT trial focuses on the bridging what we call the implementation gap, which is a space between knowing exercise is beneficial and getting young patients active. From a practical standpoint, what is the biggest hurdle in moving from a successful clinical trial to a permanent program available in every Canadian province?
What's the single biggest hurdle? There's a few hurdles. So I'll maybe share first that so when we're doing this work, we're kind of bringing an implementation science lens in. So how do we move these good ideas, these things that we need, like our IMPACT program, which is a 12-week physical activity intervention that we developed in Alberta for kids during treatment. How do we take that now and make sure that every pediatric cancer site, there's 16 across Canada, have access to refer to this? So we basically want to move this into real world. So there's a lot of hurdles, and one of the ways we're starting to try to address these hurdles is by some scaling work we're doing right now, where we're actually asking these questions. So each province so far has identified different hurdles. So the provinces we're working with, Alberta is our main site. We're scaling that to BC, Ontario, and the Maritime provinces. We're starting with these sites just because we have really high clinician buy-in, which is a big hurdle, getting clinician buy-in. And so we already have it at these sites. So we're moving ahead. And within each referring site, so the hospitals are the referring sites, we're finding that there's different barriers to accessing patients. There are different cost systems. There's different allied health personnel and availability. So what's available in BC is very different than Ontario and the Maritimes. There's also difference in terms of cancer support. So in Alberta, there's a pediatric cancer support organization that has an ongoing physical activity program. It is funded, it's paid for, it's not going anywhere. What a beautiful synergy for us in Alberta, because we're able to now kind of piggyback and can offer physical activity in an ongoing way. We don't have that in BC, Ontario, and the Maritimes. So I think there's many hurdles. It's clinician buy-in. It's making sure that we have clear pathways of referral so that we in, outside of the hospital system can reach these patients and offer them specialized services. And then, of course, a big barrier that I see, and that I think we see across fields and areas, is money. Who is going to be able to continue paying for this? How do we build this sustainably within programs or infrastructure such as our cancer support organizations? And so when we're doing our current scaling work, we're asking all these questions. We're trying to bring on the key stakeholders and get them on board early, so that as we scale now across these additional provinces, we are scaling in a way that hopefully the dream is we slowly step back from it. So at the end of this 5 years of funding, the program continues running without us. And we followed similar models in some of our young adult cancer work. And so I think at this point, we're trying to ask these questions, get these answers, and a little bit cross our fingers that there's these opportunities for us to start to step back. So I don't think I can answer and give you one hurdle, because I think there's a lot of hurdles to getting these evidence-based, good programs into ongoing care. It's a long process, and I'll maybe report back in 5 years as to what the biggest hurdle was at each site.
You were also instrumental in developing the IPOC toolkit, which is the International Pediatric Oncology Exercise Guideline toolkit. It was created to turn high-level medical recommendations into tangible resources from both clinicians and families. How do you distill those complex international guidelines into practical tools that a busy clinician can readily use during a 15-minute appointment?
Yeah, so our IPOIG was a really exciting project. We brought together international experts and created the first exercise guidelines in pediatric oncology, internationally agreed upon. And excitingly, there's new guidelines that are coming out building on this. But one of the things we realized after we developed the guidelines was a family is not going to read this, beautifully written article online. Our clinician partners, they aren't going to read it. So how we went about developing these resources is we spoke with clinicians, we spoke with families, and we found out, what do you need in order to make this something you can use? And so the things that they shared, and actually this was a PhD student who is now completed her PhD and is going on into medical school, Emma McLaughlin. She led this work as part of her master's work several years ago now. And we worked with clinicians, we worked with families, and we came up with brief little posters. We came up with infographics that now clinicians can just download and hand to their patients, and patients looked at it and said, this is what needs to be on there. So a lot of what we do, and this is a lot of what Lauren does as well, and why I'm so excited to have her with us in Canada, is we work with the people who are going to use it, and we ask them what we need to do. So we co-create, we co-adapt. It's not just us sitting here coming up with these ideas. We've got these huge teams that include clinicians, patients, parents, and other researchers. And there's no way we could do any of this without them. So we worked with clinicians, and we asked what we needed to do in order to create accessible tools that they could share and use.
Yeah, wonderful collaborative approach, Amanda. We are seeing a major shift toward these digital bridges, where we use wearables, apps, and video conferencing to deliver programs like Impact and iBounce. But there is a big question in this field regarding the human element. Lauren, having built iBounce as a digital first program, how do you maintain a strong therapeutic alliance or human connection when you only window into a family's life in a computer screen?
It's a great question. And that was actually a big learning following iBounce. So iBounce was fully app-based, and after my PhD in my first postdoc, I did a series of co-design sessions with patients, survivors, families, and healthcare professionals. And that was something that came out a lot was, digital isn't the answer. They still need that healthcare professional support. And so, and that's what we're now developing and trying to embed into the new Impact or new version of Impact called the Move Club, where we do still embed healthcare professional support in there. We have behavioral change techniques, as well as having that online aspect, so that we can reach more families across Canada, and can engage as many families as possible. But we do recognize that, having face-to-face options would still be a great option. However, it's just not that feasible in the context of pediatric cancer, where so many families are geographically dispersed. Treatment centers are concentrated in major cities. And so if we were to have something that was in person, we would have 2, 3, 4 families maybe. And so it will be really interesting to see, I guess, where the field goes within the next decade, and how our digital health solutions evolve. And we also partner with community organizations as well. There are a lot of cancer support orgs who have summer camps or other kind of in-person events to still have that sense of community. And so I think moving forward, it would be really to collaborate with those communities, and support organizations and hospitals, so that we can provide a whole range of services.
Wonderful. Amanda, I would like to hear your thoughts on how we ensure healthcare providers still feel connected to their patients' progress when the exercise is happening virtually.
Yeah. So in terms of healthcare providers, we have been working on, and this is a big part of our impact scaling work, some feedback loops in terms of ensuring that we can communicate clearly what is happening within the session, or if there's changes to the child's health with their healthcare team. Oftentimes, the folks referring into our programs are the physiotherapists or other allied health providers. And so keeping them in the loop and knowing if there's something we should be working on with the child in the context of physical activity is really important. So that's something that we try to, and that we're actually doing in a much more intentional and structured way in our scaling work, is ensuring that healthcare providers can know what's happening. And hopefully that will also help us with that hurdle that we were talking about earlier of clinician buy-in, and ensuring that clinicians see the value in this. Because often patients and families come to us after the program and say how amazing it was, all the physical and psychological changes that they noted. And we want to make sure that healthcare providers are also hearing and seeing this, so that they keep referring patients who could possibly benefit to us.
Lauren, your work emphasizes person-centered digital health. How do we ensure that the technology supports the child's unique needs and autonomy, rather than just collecting data for the sake of data?
Good question. I think it's a mixture of healthcare professionals as well, supporting the child, and really using technology as a tool to help guide each person, so that they can achieve their goals and continue to exercise, not only as a child but as an adult as well. I'm not sure if that answers the question. Amanda, do you want to jump in?
Yeah. I want to add a little more, just because we've and Lauren and I talk a lot about autonomy, and it's kind of a very important topic. One of our 3 basic psychological needs is autonomy, and so autonomy, competence, and relatedness. And so in the work and the programs, the interventions, the video conference-based delivered options, we're always trying to find ways to foster autonomy. So that can look like big choices, like what exercise do you want to do next? Or it can look like little choices, like which stuffed animal do you want to go grab and bring to this play session, or which song should we listen to? So finding ways to allow the child to have choice within those sessions is actually among our top priorities. We also, just I'm talking now, we also foster competence. So that's just helping people feel capable. So a really easy way to do that is we just start low, and we see if we can do things there, and then we slowly build, instead of starting, really hard or way up here. And when we give people little wins, we just help them feel more competent. And then relatedness is our third. And so at least with the work we're doing here right now, a lot of it's video conference delivery. So that child is actually forming a really close relationship with their trainer. And that's among the top things we hear at the end, is how much they miss their trainer. So they're meeting one-on-one, and excitingly, this is early news because we haven't started the actual scaled and adapted intervention in BC yet, but we're submitting ethics next week, fingers crossed. Within our scaled up version, which we're calling the Move Club, we're including one-on-one physical activity, and then also small group based. It's all, again, virtual and video conference, because as Lauren already shared, especially in pediatric cancer, fortunately, it's really rare. So there's just very rarely enough people at any one site for us to offer in-person offerings in real life. So we are going to be meeting virtually within this program. So kids have that chance to build a relationship one-on-one with their trainer, and then also be completing their exercises among other kids going through cancer treatment or who've completed cancer treatment. I got off track there a little bit, but I figure if we're talking about autonomy, we should also talk about competence and relatedness.
Of course, this is great. We have this incredible success story in pediatric oncology, where 85% of children are now surviving their diagnosis. But that success brings a new challenge, which is a massive population of survivors who need long-term care, often far from the specialized clinics in big cities. Amanda, how can these digital innovations, especially close to that equity gap for families in rural or lower income households?
Yeah. So, technology, I think it's exciting. It's a really exciting time for us, especially in this field, because of what you just shared. So I think technology can just be such a powerful tool for improving access. They're spread out. They need to come. Virtual programs help us reach those in rural, remote, and underserved communities. However, what we know too is that technology can also inadvertently widen some of our equity gaps if we aren't thoughtful. So if somebody doesn't have a reliable device or their own device to use, if they don't have stable internet or sufficient data, private space at home, or if they aren't comfortable with technology, then the virtual approach that we're using to reach more people might unintentionally exclude some of the people who could also benefit. So I think one of the things we often are thinking about, and I think many of our colleagues are as well, is like, who is missing? What are the barriers? What would make it easier for them? So in our current trial, one of the ways we're trying to address this, who's missing, who might we be excluding, is we're actually providing iPads with data plans to the families who need it. So the hope is that we're going to reach those who are rural remote. And if there's an individual who might not be rural remote, or maybe they're rural remote and they don't have access to a device to join, that they'll have that opportunity to take part because they'll have access to that equipment. So we'll be removing one of the access barriers. But I think anytime we start to think about equity and accessibility, in my experience, it's always a bit of a trade-off. Like we go virtual and we reach more people, but now if everything's virtual, who's being excluded because of that? I think it's one of the things that we grapple with, especially when we think about technology and the costs that are associated with it.
Yeah, for sure. Lauren, I would love your take on how distance delivered programs reshape the experience of those remote families.
Yeah, so it does so much for families living far away. I think for families living in regional and rural areas, they're already very far from a lot of supportive care services. And so to provide them with a service that they can attend from the comfort of their own home, just really closes that gap further. It really can be a powerful resource if families do have internet and have the space to attend. And I think since COVID, really technology has really evolved healthcare, with more telehealth consults being more of a norm now. And so we're hoping that when we go to test our trial, that it will help reach more families. But yeah.
Wonderful. Amanda, there's a difference between clinical evidence and a family's reality. How does involving people with lived and living experience in your research design help ensure these programs work for diverse or underrepresented family structures?
Yeah, I think having their perspectives is vital. I actually don't think we could be doing this research without them. Um, we were actually just speaking about this earlier today, David, Lauren and I, how actually we see our research questions, components of our interventions, components of our programs change when we include their voices. So I think my simple answer to that would just be that it's incredibly vital, and it changes in ways. It has changed our research program. It's changed what we call things. It's changed what we actually measure. It's changed the way the actual intervention itself is structured. And all of those changes are to reach more people, to ensure that we are meeting the needs of the people who we're trying to serve.
It's like we as researchers, we see and read all about the gaps and experiences, but at the end of the day, we're not children going through what they've gone through, and families having to care for a child with cancer. And so the thing that makes sense is to ask them, is to get them involved at every step, so that we can create something that's meaningful, and something that they will actually use in the long term.
Before we wrap up, I want to bring it back to a parent who might feel completely overwhelmed, where even the word exercise feels like an impossible task. Lauren, starting with you, and then Amanda, what is one simple, low barrier piece of advice you can offer that parent today?
The ways to engage your child in physical activity, they can be passive or they can be active. So a very simple passive way is to encourage your child, and to motivate them, and to help them, say, drive them to the park or transport them to their sport trainings. So that's some passive ways that they can support them. And then there's also some active ways as well, actually getting involved with your child. It could be going for a walk, taking your dog for a walk, doing some family activities together in your lounge room. You can definitely start very, very small, and it could just be as small as encouraging your child to do some physical activity.
Wonderful.
Yeah, that was great, Lauren. And I think one of the things, something I say often to parents when we do parent sessions, or when I'm speaking to them in the community, is that we also know that movement or physical activity doesn't need to look perfect or even be intense for it to matter. So, sometimes stretching, dancing in the kitchen, a short walk, tossing the ball, or if they're on treatment and in some of the more intensive treatments, sitting up in bed and moving a little is enough. And those international pediatric oncology exercise guidelines that we mentioned earlier, we actually simply say in those, one of our kind of taglines is just move more. And so we remind people that movement might look and feel different day to day, and that's okay. And the ultimate goal is just more movement. So I think sometimes when it can be overwhelming, we try to go back to like basics, simple, truly just helping your child move their body in whatever way they want to do, and to not think about, I think sometimes we think of exercise and we think we're going to the gym and lifting weights and running on a treadmill. And like, that's not what we're doing at all in these interventions or these programs. And that's not what kids want to do. A lot of adults don't even want to do that. So I think we try to keep it fun, playful, and really remind that it doesn't need, there's nothing that's going to be perfect about it. It can look however it's going to look. The goal is simply just more movement, and trying to take some of the pressure off of parents and their children for performing a certain way.
You both are at the forefront of a major shift. Looking at the big picture, where do you see this field heading in the next 10 years? So Amanda, let's start with you with your vision for the healthcare system, and Lauren will give you the final word on the future of digital delivery. Do you see a future where movement is a standard of care, much like a prescription in every pediatric oncology ward worldwide?
Oh, well, in my lifetime, I always say this is my career goal, is to see it part of standard care. a standard and expected part of cancer care, actually. And I will say we have colleagues in Germany and in other countries in Europe who they have exercise physiologists on the ward. They are going to every child's room, engaging them in exercise. And so I think one of my big aims in what I'm doing here now and what I would love to see before, and hopefully a long time before I retire, is that that same standard is here in Canada, and that it's the norm. So I hope so. That is, I think, what we are working really hard to do. And right now we're just working within the system we have, which is we're external to it. So we're doing these referrals out and testing that model with that being our ultimate goal and hope. So I'll say yes, I'm optimistic. That is the plan.
Wonderful.
Yeah, same here. I think I envision a world where when a child is diagnosed, the very day they are diagnosed, along with seeing their oncologist or hematologist, they're also seeing a physiotherapist or an exercise physiologist. And they continue to see them until treatment is finished, and then they can be offered more services. If that child needs additional support, then they can either attend in-person sessions or online sessions. So using technology as a tool to reach them, or they're back in the community, back in school, doing, going back to their normal or pre-diagnosis life. So I think there's definitely a lot of space and growth in technology and how that evolves. Yeah.
Wonderful. Amanda and Lauren, thank you so much for joining me today and sharing the important work you are doing to support young survivors and their families. It has been a pleasure having you both.
Thank you so much.